Okay, hang on a second. I have to say okay to the recording. I use the term for historical accuracy. Also, I'm aware of the debates and the politics around the word addiction. Since this talk is about those politics, they're kind of impossible to avoid, and so I prefer to just confront them head on by using the word that's historically accurate for the time periods we're talking about, but I'm definitely open to all of the conversations and debates that raises. In fact, they're sort of what this is about. So this talk covers familiar ground for me. This is from my second book, White Market Drugs. And what it does is it tries to draw broad policy lessons from the historical drug crises that I looked at, what worked and what didn't work, and kind of distill them to think about how collective responses can either magnify or minimize individual risks so that they become public health crises or they don't. Let's see. When the opioid crisis first hit, most observers, like you can see in this Buffalo News articles, called it an unprecedented and new phenomenon. They said, addiction is leaving its traditional home in poor and racialized cities, and it's cropping up in white suburbs where it hadn't been before. And this is strange because there were lots of precedents for this unprecedented thing, tons of them, stretching back over 100 years, all the way back. I'm just going through some headlines. You got the 40s and 50s here, and then all the way back to the late 19th century. And these headlines alert us to an alternate history of addiction that never primarily took place in cities or among racial minorities, that had long been entrenched in the relative privilege of white middle-class neighborhoods, suburbs, and rural areas in places that I call white markets, which are legal medical markets for psychoactive and potentially addictive drugs. Now, these white markets weren't always in crisis, although the headlines sure make it seem that way when you go through them. Instead, the crises came in three big waves. The first involved opioids, and it peaked at the end of the 19th century. The second involved sedatives and stimulants, and it peaked in the late 1960s and early 1970s. And the third, that we're all more familiar with, involved all three classes of drugs in the early 21st century. And when you look at these crises, they also reveal that not only did America have an alternate history of drugs and addiction, but also has an alternate history of drug policy. Because when authorities responded to these white market crises, they didn't resort to prohibition and drug wars. Instead, they developed a whole different set of policies that turn out to have been remarkably effective, at least in the context of America's drug history, which is a context that sets the bar incredibly low because it's been a series of disastrous failures. These ones kind of worked, and so they're worth looking at and thinking about what we can learn from them. I'm just going to give a really quick, big overview. The policies had two main elements that I want to emphasize today. First, they recognized implicitly or explicitly that the fastest way to magnify individual risks of addiction and other drug harms into public health crises is what I'm going to call, with a shorthand term, of flooding. And flooding is exactly what it sounds like. It's a situation in which a community becomes so awash in a particular drug that that drug is just ubiquitous. It's extremely easy to get, probably easier to get than alternative drugs. And I'm not just talking about legal barriers. I mean, in a case of flooding, consumers barely have to face even relatively minor practical barriers, like, say, driving to an unfamiliar neighborhood and making new relationships, or paying high prices, or having to wait before making or using a purchase, and so on and so forth. So in other words, in a case of flooding, drugs are just kind of universally available, and this ease of access tends to normalize them, tends to make them seem like something that everybody's doing. There's a very low psychological barrier to using them. And in the case of these white market crises where flooding happened, the effective responses aimed to reduce new cases of addiction and related harms by ending the processes that created flooding. It may seem really obvious, but it's an important distinction because it was not prohibition. Prohibition tries to end drug sales, right, and end all the problems related with drug sales. This was something much more calibrated. It was regulation to introduce practical, not punitive barriers to accessing goods that are quite dangerous. Just enough friction to prevent flooding while allowing the goods to still be sold and still be available. In particular, the second point up there, that and this was particularly important once you are in an addiction crisis. This included tailored, safe markets for those with chronic need, either due to addiction or other health reasons, variety of health reasons. So that's the big, very oversimplified picture. Let's go through the history and see how it worked. I'm going to march relatively quickly because it's lunchtime and you all have busy lives and there's plenty of territory to cover. But there'll be hopefully time for questions if I say go through something too quick. So the first crisis, this was in the late 19th century. This was the period of industrialization and also the period of laissez-faire economic policy. That means basically just let markets do what they're going to do. This was a period of consolidation in which the nation saw the first really big corporations, giant corporations. They were selling lots of new and unfamiliar products, lots of high-tech products like syringes, and they didn't have a lot of restraints on what they could do to sell their products. The rule of the markets was caveat emptor, which is Latin for let the buyer beware. And that was, you, as the consumer, you were supposed to protect yourself by making sensible decisions. As you can see on the slide, some of these new high-tech products were more powerful drugs, like morphine, like cocaine, like heroin, used in new ways, like using syringes to inject. And these new products were pretty rough on caveat emptor. Caveat emptor requires that a consumer have enough information to make smart decisions. These were new products that people had no experience with, and they were being very, very widely promoted for a wide range of uses. Physicians, if you go through the medical literature at the time, they used what they sometimes called Saint morphine for almost everything. Headaches, diarrhea, syphilis, rheumatism, insomnia, anxiety, overwork, masturbation, nymphomania, violent hiccups, something called female complaints, and the list could go on. I'm just drawing out some of these. And as sales shot through the roof, medical markets became flooded. Opioids were just ubiquitous. They were in as many as 25% of all prescriptions. They were also available at the pharmacy without a prescription too. And you can see here, this produced a dramatic rise in the number of people experiencing addiction to opioid. And this experience was predominantly among native-born white folks with enough money to be able to afford to go see a doctor. And you can see this is a painting from 1888. It's not an American painting, it's a French painting. I don't know if you can tell the standing up woman has got a syringe. She's injecting her upper arm. Observers were aghast at this, and they tried to make sense of where it was striking. One wrote that, quote, a higher degree of civilization, bringing it with it increased mental development among all classes, seems to have caused the habitual use of narcotics, once a comparatively rare vice among Christian nations, to have become alarmingly common. So you have that sort of, oh, this is a surprise. Addiction is cropping up somewhere where it's not supposed to be. Observers saw addiction as mysterious and horrifying, but they viewed the people experiencing it as innocent victims of a medical market that had run amok. The vast majority of Anglo-Saxon opium eaters, Harper's Magazine explained, first learned its seductions through a medical prescription. The New York Times, in the article on the screen there, agreed. Far from being a vice, they wrote, the morphine habit is actually a disease, produced not through the culpability of its victims, but in consequence of their physical and mental ailments, and chiefly through the instrumentality of their physicians. To no class of unfortunates should our floodgates of pity, sympathy, and commiseration be wider opened than to the victims of opium. So, in a situation where addiction is caused by a market going out of control and it's inflicted on innocent victims, reformers stepped in to restrict the supply, to end the flooding. In medicine, therapeutic elites, the doctors at colleges and universities, influential leaders, they exhorted their colleagues to be more careful in prescribing. Don't turn to morphine at the first drop of a hat. Only use it with great caution. And if you do use it, don't tell the patient that you gave them morphine, because remember, they can just buy it without a prescription at the drugstore. So don't tell them what you gave them. And there's a rapid and dramatic reduction in medical prescribing starting in the 1890s. And then in politics, the progressive reformers passed the 1906 Food and Drug Act. It's the first consumer protection law in the United States, and it required honest labeling, which had to include, it couldn't just be truthful, it also had to include any of what they called narcotic ingredients. Their ideas of what constituted a narcotic were weird. Don't have time to get into that. The law is enforced by the Food and Drug Administration. So notice that neither of these reforms was about prohibiting any particular product. The goal was consumer safety. The goal was to end a situation where these drugs were just so ubiquitous and so easily accessed with so little warning that consumers were exposed to unnecessary risks. Meanwhile, though, we're talking about 1906. Okay, so this has started in the 1870s. So medical sales had been so vast for so long that popular markets for the drugs had sprung up, especially in major cities among the working class children of immigrants from Catholic and Jewish parts of Europe, folks who generally didn't have the money to visit physicians. And so they bought in these popular markets where, back alley pharmacists or from someone who bought a bunch from a pharmacist and then resold on the street. Now, progressives already did not like these people. They referred to them as the dangerous classes. They tried to restrict their right to vote. They were on the verge of shutting down immigration because they really were unhappy about them. And they viewed the people of these communities who used opiates with much less sympathy. They didn't see them as innocent victims of a market run amok, which in fact they were. They were facing the same kinds of issues that people who went to doctors were. They were pursuing pleasure, or they were trying to ease suffering, and they didn't know enough about the products they were buying to use that. Anyway, they saw the reformers saw these as really different. These folks didn't need protection. They weren't innocent victims. They were purposeful deviants and criminals who society needed protecting from. So they passed the 1914 Harrison Act, which criminalized all non-medical sales and non-medical possession. In other words, this is that drug prohibition policy. And for good measure, the act also made it illegal to prescribe opioids to a person who was already addicted to them. Now, for popular markets, this was a disaster. The most common drug used in popular markets had been smoking opium. But smoking opium was a terrible smuggling product. It was bulky, it was stinky, it was not designed to succeed in an illegal market. But in these popular markets, people who had developed an addiction to opium were strongly motivated to continue using it. And so they shifted to a product that was better suited to smuggling, and that was Bayer's heroin. In other words, prohibition spurred a shift from a relatively safe form of opium to a far more dangerous product, heroin for injection. And heroin markets essentially remained in a public health crisis for the rest of the 20th century. As a matter of fact, until they were displaced by fentanyl in a development we'll talk about in a little bit. So this prohibition policy was pretty disastrous. Something more interesting happened in white markets, which is that opioids remained available, but their sales remained stable, and there were no public health crises associated with pharmaceutical opioids for pretty much the next 70 years. So you can see here at the beginning of that graph, you can see that uptick. And the reason why this graph looks so shrunken is because, of course, it goes into the present day, and the present day's opioid sales boom was much larger. But you can still see that dramatic rise in the late 19th century, and then the decline in those policies. And then for the next, 70 or so years, it remains pretty consistent. How did that happen? On the one hand, federal authorities used the new powers of these federal laws to fight off wave after wave of would-be miracle opioids that were launched every few years from the pharmaceutical industry. OxyContin was not the first of these. It was like the 74th of these. You can see one here, an example. Demerol, when Demerol was first introduced in the 1940s, there was a huge media blitz. The company tried to persuade the world that it was non-addictive. And this is an article in the Washington Times-Herald talking about how non-addictive it is. The federal authorities had the power to prevent this kind of action, which was intended to flood those markets once again with one of these opioid products. On the other hand, oops, I didn't mean to have that slide in there. On the other hand, white market opioids also still had an avenue where they could sell opioid products to people who had developed an addiction to them. Now, technically, this was illegal, right? And so it was done under the table, but it was relatively easy to do at a small scale because the drug prohibition had been targeted at those urban dope fiends and not at, say, a few respectable patients seeing a family physician in Kentucky. And so this access to medicinal opioids for people who'd become addicted in that first late 19th century crisis, it wasn't systematic. There was no official formal system to do this. It was this archipelago of individual family physicians just maintaining a few patients here and there. But as far as I can tell, if you add up all of the people doing this, this was probably a significant majority of the people chronically using opioids. In other words, people who had opioid addiction in the United States, at least through the early 1960s. Kentucky, for example, had the nation's highest per capita rate of opioid addiction in the early 1960s. Even though all the media attention was on people using heroin in New York City, there were per capita more people using opioids in places like Kentucky. And you can see here a letter where sometimes these folks would run into issues where the doctor prescribing for them would die, and they would plead with the federal government, hey, can you give me a special license? The new doctor is scared to prescribe for me. And sometimes the federal government, would agree, say, yep, you'll be able to do your job better if you get provided. So just to recap that first crisis, white markets got new regulations that were designed to prevent flooding, even as doctors continued to provide opioids to white market consumers who needed opioids. And this included, most importantly, the generation of people who had become addicted during that period of time when the markets had been flooded. It also included people who needed opioids for all the other many things that medical reasons that people need opioids. Meanwhile, prohibition markets had shifted to a more dangerous drug and experienced wave after wave of public health crises with opioids throughout the 20th century. Okay, so that's the first crisis and those anti-flooding policies. The second crisis came when, after the crackdown on opioids and cocaine, and the pharmaceutical industry was unable to inflate new sales booms for those drugs, they discovered alternatives to replace heroin and cocaine. They launched massive marketing blitzes for new sedatives like the barbiturates. You can see the first one there on the left, and stimulants like amphetamine. And by this time, because the people who were being maintained by doctors were they were able to maintain their privacy as compared to the public spectacle of heroin use in cities, addiction had become associated with heroin and those mixed race, urban, poor neighborhoods. So it seemed like addiction was a quality of those people more than anything else to authorities and observers. And so these new products, these sedatives and stimulants, they weren't opioids. As you can see, they were really carefully marketed to affluent white people. They were able to escape regulation. They were able to escape this, the idea that they were producing addiction. It wasn't even until 1952 that Congress required a prescription for the sale of these drugs. And even then, policing was lax, penalties were very minor, and it wasn't illegal to buy or possess them. It was only illegal to sell them. And the result was a massive boom in these drugs, which are quite pleasing to use. I'll just give one little tiny example from the town of Kiel, Wisconsin, a tiny town tiny town of Kiel, Wisconsin. One physician there was prescribing like a huge amount of amphetamine, which he explained, as you can see, little excerpts from here. He gave to, quote, make patients feel a little peppier. He said it helped women, quote, keep up with the housework. And sometimes he gave them a prescription simply because, quote, they're paying for an office call and want relief. They don't want you to go home and take 2 aspirins. But he assured, when he talked to the county medical society, he assured them there's no need to worry because Kiel doesn't have a black market for drugs. He said, not like the city. He said, we're not like the city. And I'm reading this, doing the research and thinking, well, of course, there's no black market in Kiel, Wisconsin. This doctor is prescribing anybody with any drugs they might want all through legal channels. You don't need a black market. In other words, little tiny towns like Kiel, Wisconsin were once again flooded with potentially addictive products that were universally available, that had a medical stamp of approval, that were being used by respectable people, that made them seem normal, safe, and unobjectionable. This produced another public health crisis, this time with significant numbers of fatal overdose, which had not been characteristic of that first crisis. Fatal barbiturate overdoses alone, just them, rose 5-fold between 1933 and 1953. This doesn't count automobile accidents, it doesn't count problems with amphetamine, and continued to rise after that. And you can see here that while they don't get anywhere near as high as the 21st century opioid crisis, this isn't some cute old-timey public health crisis. This was significant. And it wasn't just people who were prescribed these pills. When communities are flooded, everybody gets access to them. Authorities estimated that up to half these pills were diverted, but most of the diversion took place within the communities where they were mostly prescribed. In other words, small towns, suburbs, so on and so forth. And it's worth noting, just as a side point to address, because there's a lot of discourse about deaths of despair, this was a case where the communities involved weren't facing extraordinary social pressures or despair. White middle-class neighborhoods in the 1950s were really well off. I mean, you could argue that women's status, housewives, was stressful and constrained. And it's true that women were much overrepresented in these statistics of drug-related harms. But even so, it would be hard to make the case that this was a deaths of despair in the way that we've come to understand that concept. It suggests that regular, just ordinary despair, just like regular life despair that everybody has, is enough to foster a crisis when a community is flooded by potentially addictive drugs. Authorities eventually responded to this crisis with new laws in the 1960s and 1970s. Kind of a culminating centerpiece, but only one part of all these laws, was the Controlled Substances Act of 1970. And these extended robust regulations of white market sedatives and stimulants by restricting advertising claims, by placing new constraints on automatic prescription refills, which had been endless up until that point, by requiring all sales to be reported to authorities, so introducing market surveillance, so you could tell when there were like weirdly large numbers of sales, by limiting, for the most dangerous drugs, especially amphetamine over the course of the decade, they limited the number of indications that you were permitted to prescribe those drugs for. Indications for amphetamine shrunk a lot before they exploded back up again with ADHD in the 90s. And they also placed legal responsibility on pharmaceutical companies to ensure essentially that they weren't flooding the market, that all sales were legal and appropriate, and they would be legally liable if that wasn't the case. Now, it's important to recognize that there were no newly prohibited drugs in these laws. All the drugs remained available, all the ones that had been available remained available, and were still available even for long-term use. So, for example, people who had already developed a need for them, people who were on long-term treatment with amphetamine or Valium, they were not suddenly cut off. It was still legal to prescribe for them. However, laws reduced the ability to be on autopilot about this, or the ability to unthinkingly create new situations where people are in long-term use or develop an addiction without making deliberate choices along the way. And so it introduced frictions, in other words, that reduced the chances that when people encountered these drugs, their encounters would turn into a bad relationship with those drugs. It also, by virtue of the flexibility of having the ability of those 5 schedules and the ability to kind of tailor make the markets, they encourage markets to shift towards safer drugs. So, for example, the law favored benzodiazepines like Valium over short-acting barbiturates. It became easier to get the drugs that were safer to use. So in other words, these policies looked like a kind of a modernization or an update of the ones that had effectively brought the morphine crisis to an end back at the turn of the century. They ended the flooding, but they kept the drugs available, including to people with demonstrated chronic need. So you didn't see what you saw in popular markets in the early 20th century. You didn't see a whole bunch of people cut off from white markets and then having to go and find some illicit drug to replace the one that they couldn't buy anymore. And there was another point I was going to make about this. I can't remember what it is. So this is again where this kind of policy that was quite effective at ending the crisis was really tailored to these white markets. Now, I'm going to shift to the third crisis, and here's where you see that whole graph of opioid sales that I had before. And most of us are more familiar with this one, so I'm going to be briefer in going through the history of this one. But essentially, after that 70-year period of robust anti-flooding opioid regulations, pharmaceutical companies, opioid manufacturers, finally broke free of the restraints. And they did this for a few different intersecting reasons or through a few different strategies. First off, there genuinely was a problem of undertreated pain in the United States, and some careful conservative expansion of opioids probably would have been a part of addressing that problem. So there was a kernel of need for more opioids. Maybe the controls had been a little too robust in some situations, like like cancer pain and other areas. Then awareness of that pain problem came right as the Reagan era was flourishing, and the idea was that you could solve social problems by slashing bureaucratic red tape to unleash the private sector, whose creativity and innovation would then solve those problems better than the government. So you had a pain problem right as deregulators were looking to unleash the private sector. And so the opioid industry saw their chances and unleashed the 77th opioid product that they claimed was new in some way and was going to be non-addictive. And they also really carefully targeted their initial marketing to white and non-urban parts of the United States. They did this because in the 1990s, the US was just at the tail end of the crack cocaine crisis, which had once again associated the idea of addiction as something that took place in cities, predominantly among racial minorities and the poor. And that meant that if you had a product that was being sold to people who looked really different than that your claim that it was non-addictive, that was going to be a little bit more believable, because once again, a lot of both authorities and popular culture had begun to conceive of addiction as a quality of a certain kind of person, identified demographically, like poor, Black, brown, whatever, and rather than a quality associated with a kind of product. So they really targeted their marketing at the upper Midwest, Appalachia, New England, places that were white and not urban. And when they did this, they didn't essentially, instead of the tall order of saying that an opioid is non-addictive, they had to do something a little bit easier. It's the sleight of hand is saying, well, we're prescribing when an opioid is sold to treat pain, used to treat pain, then it is non-addictive. And all of their advertising made clear that pain was something that was happening to these rural white people. And so when you thought pain patient, you were thinking the kind of person who doesn't get addicted to drugs. And that allowed this kind of bizarre, frankly, claim that opioids were non-addictive to get the legs that they did. We're so used to having lived in the world that was created by those arguments that it can be hard to remember, like, well, wait, advertising isn't that great. How could you convince people of something so contrary to what they had always thought? And the result was that these white and suburban and rural communities were flooded with opioids. And the story that we're all familiar with. One town in West Virginia had 80,000 people. They got 8 million pills. This wasn't just giving a lot of pain pills to people experiencing pain. Opioids were everywhere in these communities. They were easier to get than other safer drugs. When you showed up at the high school party, there were pills instead of weed. Easy, maybe easier to get than weed and beer. And so once again, this universal accessibility, this incredible ease of access, combined with their medical imprimatur, made them seem normal and safe, and lowered the lowering the practical barriers also lowered the psychological barriers to use. And the result was the first phase of the opioid crisis. This is the wave of addiction that swept through precisely those places that had been targeted for opioid marketing, the upper Midwest, New England, Appalachia, so on and so forth. Now, when authorities moved to address the crisis, we're talking about the mid-2000s, opioid industry lobbyists persuaded them that the basis of the crisis wasn't the drugs were fine, but it was the abusers, in other words, the people with addiction who were ruining it for everyone. Lobbyists they speak very loudly to politicians. Politicians were persuaded. And so the first round of reforms were designed not to stop opioid manufacturers from flooding the market. The first round of reforms were designed to stop people with addiction from buying in those flooded white markets. So they implemented prescription drug monitoring programs, for example, to prevent consumers from doctor shopping or refilling their prescriptions early. And they clamped down, on so-called pill mills. And this produced a generation of people who had developed addictions to opioids who were locked out now of the markets where they had previously been buying them. And so they became this up for grabs new consumer base, people who were very strongly motivated to keep buying and keep using opioids, but didn't have anywhere to buy them. And new illicit suppliers stepped in to serve this new population of consumers. That's because existing illicit markets couldn't serve the needs of this generation of people. Existing markets were connected opium poppies in fields in places like Asia, and connected them to major American cities like New York, Chicago, and LA. The people in the upper Midwest and Appalachia and New England and so on, they didn't live in those cities. So this was a moment of market disruption where long-established patterns, long-established traffickers, long-established infrastructure was upended and new people moved in. And the new suppliers looked at this and said, man, it's the 21st century. We don't need fields of opium poppies. We don't need to only sell things in special districts in cities like you used to only be able to buy a high fashion in New York City. This is the 21st century. We're going to bring a new product that's synthetic, fentanyl. We don't need all the farmers and fields. And it's so much more potent than heroin that you can get a lot more in a smaller package. So it's a better smuggling product, just like heroin had been better than smoking opium. And we're going to use new supply chains to deliver this stuff across the country to the places where the people who want to buy it are. And this inaugurated this second phase of the crisis where fentanyl replaced heroin, and it shifted from a crisis of addiction to a crisis of fatal overdose, because fentanyl is very hard to package for safe consumer use. You need to be incredibly finicky because even tiny clumps can produce overdose. Prohibition markets don't incentivize that kind of finicky care in producing products. They incentivize avoiding arrest. So by the late 2010s, opioid policy shifted again, focusing more on limiting the intentional flooding of white markets by the opioid industry. And this kind of supply constraints were combined with specialized markets for people who were experiencing addiction. So, for example, buprenorphine prescribing was dramatically expanded. Drug testing kits were made available. In some places, safe injection sites were opened, and there was more investment generally in forms of addiction treatment. And this combination approach, once again, has finally started to turn the overdose curve around in recent years. But as the crisis has shifted from its original demographic base in these white suburban and rural areas to major cities and racial minorities, there's no guarantee that these kinds of policies will continue. There's that the historical pattern has been to apply these effective policies just to white markets and their consumers. And the moment the crisis is over in the white markets, you snap back to those drug war policies that have been repeatedly failed by any measure, but especially by public health measures. They tend to result in more dangerous drugs and a greater likelihood of public health crises surrounding drugs when communities get flooded with them. So, man, I must have been talking really fast because I'm already at my conclusion. That's lovely. We'll have plenty of time for conversation. I just want to wrap up with a final observation about these anti-flooding policies and their implications. It's not just free markets that lead to flooding. The same can happen under prohibition. The waves of heroin addiction in major cities in the 1950s, 1960s, 1970s, and 1990s, and the crack cocaine crisis of the 1980s and 90s, all of these took place in neighborhoods that were flooded with these drugs, where these places with the infrastructure to sell these products, they had communities living in that infrastructure so that they were just all too easily available, and led to the same kind of public health crises that we saw in the white markets when they were flooded. So one of the policy takeaways is to escape the binary thinking that you're either going to have prohibition and drug wars or like legalization and free markets. This is like one of those U-shaped graphs where the two extreme ends look a lot like each other. They both prohibition and legalization are potent contributors to this condition of flooding, and thus they are both potent contributors to public health crises related to drugs. And instead, it's worth looking at the vast policy space between those two poles. As in this talk I've shown, we've already done for the largest drug markets in America. Obviously, pharmaceutical markets are massively bigger than illicit markets for the same drugs. And while these markets have periodically faced crisis, we have implemented policies that have resolved those crises quite effectively. And while prohibition has been a disaster and kind of just free legalization or free markets has been a disaster, this in-between stuff where you're calibrating the market with the specific goal of introducing friction and barriers that don't eliminate people's access to drugs, but just make it make it less likely that access will lead to the kinds of outcomes we don't want, which is harmful use such as addiction and other related harms, that we should consider adopting the policy that works more widely rather than restricting it to a particular place under the theory that the people in those markets are somehow just fundamentally different from the people elsewhere. And instead think about introducing these policies as a way to protect everybody from the kinds of public health crises that can result when communities are flooded by potentially addictive drugs. All right, thank you.
Thank you, David. I'm going to open up to anyone who has questions. Just unmute yourself and address Dr. Hertzberg directly.
There we go.
if you're all thinking about it, I can ask a question. So, David, earlier in your talk, you were talking about, these different populations and how one's got marginalized. And a couple times you crept in and you said something about how the healthcare, the inability to access healthcare in those marginalized populations contributed to that. And so I was wondering if you can expand on that, and if do you have lessons from countries that have perhaps universal healthcare or other systems that you can draw upon and illustrate for us.
Yeah, I mean, it's a little strange, but I mean, or it's a little complicated, I guess, that people who are locked out of, or not locked out of, but don't have privileged access to what I'm calling white markets, or we could call the medical system, they sometimes in the midst of one of these crises that can be a little bit protective in the sense that exposure to access to white markets can be a risk factor. Of course, that's kind of a bitter benefit because it also means you're not getting access. Like there's a reason why these drugs are prescribed. There's a reason why they're used in medicine. There's a reason why people use them. And if you don't have access to that to ease suffering, that's a problem for you. So in this case, it wasn't so much the lack of access to white markets that caused those popular market or illicit market crises at the turn of the century in the first crisis. It was really just simply that all consumers were confronted with the ease of purchasing powerful new drugs that they didn't have a lot of experience with or information about, and the rules were so lax that that enabled people who didn't even have the ability to go see a doctor or a pharmacist, they could buy it from someone on the street. I'm not sure if I addressed the import of your question there, but you can follow it if I missed the mark.
Go ahead, Ken.
So, as usual, David, that's very timely and very an outstanding presentation. I guess the point that I'd like to make, I'm sure you agree with this, is that one of the effects of flooding is that flooding and the perception that these things are not harmful is that the reasons for their use expands. And so it's no longer just I have some pain, but it makes its way into the recreational market. And that's a lot of what we saw in the later 2010 were deaths because of people who were getting it recreationally or getting it from people who got it medically. So that's an important element to be thinking about in terms of the policy.
Yeah, so for me, as a historian, I don't draw a line between the use of drugs to relieve suffering versus to pursue pleasure because I don't have the expertise to draw that line. And also, I'm just in general skeptical that there's a really clear line. I know that at the extremes, there's definitely a difference between those. And so to me, what you're saying is exactly right because when a community is flooded, that means you can access them for any reason. The reality is that the number of pain patients who had never had problems with drugs or behavioral health before, who got a new addiction from being prescribed opioids, really was low. But it didn't matter, because when the community is just awash, I just keep thinking about, imagine you were in high school and you're going to one of your high school parties. What was there for you to use? And what did you know your friends were using so it didn't seem like a crazy thing to do? And if you got 8 million pills flooding through your tiny town, what's easy. And so I don't get into saying, well, and that's recreational, in part because you don't know what someone is experiencing who doesn't go to a doctor and who uses a pill. Like they could also be having pain, but just not going to the doctor. But the same rule still holds. Yeah.
Yeah, but when you ask these people about their motives for use, um, it's not for pain, right? That's the I think the takeaway message there.
Mhm.
When they're asked about it, it's to get high or it's for pleasure. And you're right. It's sometimes difficult to distinguish kind of a bright line from that. But these were by and large not people who were out motivated to get something because they had chronic pain.
Yeah, I mean, I guess for me, the reason that I would tend to de-emphasize it is because even amongst people who are using opioids recreationally, whatever, wait, is it 80%? Is it 90% of doesn't lead to the kind of harmful outcomes we don't like? We don't, I don't ever hear policy conversations around, well, how can we make that 80 to 90% like 99%? It's all just about, we just need to cut it off entirely. And I'm just saying, we have, we've been doing capitalism for centuries. We know how to manipulate markets and create incentives for dangerous products. And so like, I'm sure that recreational use is a greater risk than pain use, but it's still not it's nowhere near automatic. It's a very minority. And so it's just a question worth asking of how do we, like, would that 80, 90% go to 90 to 99% if we just created barriers so that it's not like you just, once you break through prohibition, you can just do whatever you want? What if, it was available, but there were waiting periods, or it was available, but from people who said, you can't ever use this 2 days in a row, so just wait another day. Those kinds of things, simple, kind of prosaic, the kind of things that we use in white markets and that makes them a lot safer. Lorraine, I see your hand.
So David, thank you for your talk. One of the things that struck me about your final slide is this issue of prohibition followed by flooding. And sometimes I feel like that's happening in the cannabis area, because we've had in the past, well, since 2012 or so, we've had probably close to 2 decades now of prohibitions being relieved. And I really worry that we are now in that U-shaped curve that you described. And I'm just curious, this is not an opioid question, but any thoughts about that with regard to cannabis?
And okay, yeah. I was wondering which drug you were thinking about. To me, like, I can't, I'm a historian, so I can't spend tons and tons of time reading up on the very latest data. But from a historian's perspective, the cannabis thing seems like a great example of why it's so hard to stick to this large middle ground here, that like it's either legal or it isn't. It's like one day it's illegal, the next day, like every block I walk on has got another dispensary, people, and I'm like, if there's a way to make cannabis dangerous, we're about to find out what it is. Like, maybe we'll luck out and it isn't, but it seems like a terrible a terrible way to go forward that is historically really likely to snap back into prohibition, because legalization causes problems and that really upsets people and causes a lot of pain and suffering in families. And then you snap back to this emotional response of like, we just got to shut it all off. Whereas, we're just so good at this with other products. We're so good at, I mean, I always just go to cars and airbags and anti-lock brakes and, all of the various things. But we seem to go from boom to bust in drug policy without looking into a more calibrated, careful approach, and basically sacrifice the people who are gonna pay the price for flooded markets, like the people who are just gonna be the unlucky ones in that scenario.
Thank you. I agree, and I am worried about what's going on with the flooding. Thanks a lot.
Yeah, I think about that with ADHD pills too, by the way, like a grand experiment, just like every student has unquestioned access to them. Who knows what will that look like as they grow up? But Nancy?
Hi, David. Great job as always. I just want to comment because there is absolutely no question that physicians played an unsavory and sometimes unwitting, but an unsavory role in over-prescribing these drugs. And, you know, we have seen that repeatedly in patients, including kids in high school who get prescribed opioids for a football injury. And that's the beginning of a downward spiral. And yeah, I want to contrast what I'm talking about from what Ken said, which was recreational use. Once they're hooked, they do not take these drugs to get high. They take them to keep from getting sick. It's not about feeling good. It's about feeling at all functional. And so the effort to change physician behavior, because frankly, the pharmaceutical, I mean, we all know the story. We really all know the story. And in my opinion, the Sackler family ought to be in jail for what has happened. There's no amount of money that brings back the lives that have been lost and ruined. And yet, as you point out, the pendulum then swings. Even when you try to not have it swing too far, it does. For example, when CDC issued the prescribing guidelines, that was interpreted by law enforcement as an absolute maximum, which is just not right. I mean, it's loosened a little bit, but I think we really need to pay attention to our, you know, those of us who are clinicians, to our own role in this, how we got gobsmacked by this, how we got sucked in, and in some cases, how there was a behavior that was totally unprofessional and criminal. But the majority of the prescribing was not that. It was, you know, being used for pain too long, and then resulting in people who now need opioids to avoid being desperately sick.
Yeah. Yeah. I mean, one of the things that I took from, I spent a couple of years as an expert witness in the opioid litigation case. And so I spent a lot of time in these millions of documents that are now available online at the UCSF's Opioid Industry Documents Archive. But that was one of the things that really struck me was how much I liked and admired a lot of the physicians who became conduits for opioids. These were people who cared about pain patients, who they thought they were using the opioid industry to accomplish their goals of patient care. And then there were a lot of other physicians who, if you were an on-the-ball physician reading the latest guidelines from your specialty organizations and from all the people that you trust, and so it's a lot of the best physicians were guided into doing this. And so, like, examples of bad behavior are there, like you said, but also, like you said, the great majority of this was not, you don't, if you're looking for ill intention, you got to go way up the food chain for the most part. And that, once again, like in my vision here, like there's no point when I said these crises were resolved, they didn't disappear. They weren't gone. They just weren't at crisis levels anymore. It returned to kind of endemic. And that's, my philosophy is aim for least worst. You're going to have, there are still car crashes that kill people despite all the safety innovations, and that the point is to just try to reduce and minimize this flooding so that you have a kind of a manageable level of normal human problems rather than something that's just galloping out of control. And that this can, that, and my belief is that this is a little easier than it can look, because prohibition is so hard that it's impossible. But I think even little bits of friction have a huge impact on how these markets work. Just something as simple as like having to wait a day or having to drive to another neighborhood. These little bitty bits of friction turn out to have huge impacts. Big companies do not like this. Big traffickers do not like this. Friction means less profit. So that's a political problem in trying to introduce friction, but it's still going to be easier if you can sort of make that deal of like, hey, if you put up with this regulation, you get access to a market, you can make profits. We've had some success in making deals with people who want to sell stuff, getting them to accept limits so that they can make a legal dollar. And that's where my thoughts on this kind of head after thinking over the history for for a very long time.
So we have time maybe for one last quick question, if there is one. If not, I want, on behalf of everyone, thank you, Dr. Hertzberg, for a wonderful talk. And as you've heard, he has things at the UCSF archive. He has articles online. He has a wealth of things, and he told me he has a new talk that he's developing, which I don't know when you'll be ready to give that to us. But I want to thank you on behalf of
Yeah.
everyone. Thank you.
Thank you. The next book project is on addicted doctors.